And then looking at COPD, looking at asthma and kind of what goes on. When you're talking about your COPD, this is more of an issue where it's not as reversible as when we're talking about asthma. When we give some of our medications in asthma, we'll have our patient respond to it and we can reverse that bronchospasm that we're having. When we look at COPD, this is like a more gradual process that happens over time, and then eventually what ends up happening is they have an airflow limitation. You'll see different things and your patients present in different ways. Sometimes they'll have more mucus, which then increases their risk of infection because those bugs that are trapped in the mucus then get trapped there and they can grow. And then you have where their cilia, which are supposed to be able to move things out, right, push things along. If those are inhibited, then again, things stay there for a longer period of time, increasing the risk of them having an infection. So this is just some of the pathophys. Remember, I'm not testing you on any of this. It's just to let you know what your drugs are looking like when you're with your COPD versus your asthma. This is up here not for you to remember every single thing, but to understand that this is essentially an assessment tool that you can use to see the severity of someone's COPD. Okay, so when we're looking at our MMRC, this is going to come into play later when we're talking about the classification of COPD. There's different classes that we have, but your MMRC is a Modified Medical Research Council dyspnea scale, and that's essentially saying how breathless are you. So if I have 0, this is saying that it's provoked, right? Like I'm going and exercising, am I out of breath? Most people, right, that can happen to even a normal person. Whereas when you get to your grade 4, they can't even function, right? They're not able to leave the house. They may not be able to get up out of a chair and go walk to another room without feeling extreme breathlessness. So you have 0 being the best and 4 being the worst. And then this is your CAT score, which is a COPD assessment test. And this is, again, just seeing what the severity is, how bad is your patient, as far as being able to get up and move around, do their normal ADLs, like their normal activities throughout the day. So when we look at our meds, there are going to be several different drugs that we have, some of which we have already talked about. So again, remember while you're studying to look at what you're using in COPD versus what you're using in asthma, and just understand a lot of these are going to overlap. They're just different. And this is also the thing that I was telling you about with the guideline. Depending on what guideline you use, you may see a different way in which you're going to manage your patient who has asthma or COPD. So looking at the meds that you typically would see used here, these are all of our beta agonists. We've talked about some of these. These are broken up into your SABAs or your LABA. So SABA is short-acting, LABA is long-acting beta agonist. You have your anticholinergics, so you see a SAMA and a LAMA. So SAMA is short-acting, bless you, LAMA is long-acting. So giving you the difference between those. And then this is you having a combination of the beta agonist with an anticholinergic medication, bless you, but it's in one inhaler versus them having to carry around 2 different inhalers. Same thing, this one's short, this is long, but both of them are going to be coupled with the anticholinergic agent. Then these are some other drugs that you'll see used, your methylxanthine. Not as commonly used anymore as we used to back in the day. Now it's kind of different settings where you'll see these being used. Again, a LABA with a steroid. So just like we talked about before with our allergies, you can have a coupling with a steroid. You can have a coupling with an antihistamine. So these are, anticholinergics. So these are your anticholinergics. This one is coupling it with a steroid. And then this is your triple combination, which has your LABA, your LAMA, both long-acting, with your inhaled corticosteroid. So again, limiting the number of devices that patient has. So when you're looking at TRICARE in our formulary lookup tool before you're like prescribing a medication to a patient, if you see that one of our dual inhalers or this triple inhaler is not on formulary, just order all 3 and tell them to take it, right? They're still getting all those same medications. They'll just separate out their puff so that they get all of those medications in. Phosphodiesterase 4 inhibitors or your PDE4 inhibitors. We have one, your roflumilast, and then your mucolytic agents. These are just things that are trying to help with that mucus, because remember we said that they're going to have a buildup of the mucus. So this is just trying to help with that. We'll go through the different types of devices and how they are delivered. So you'll see HFA, DPI, SMI. You have a nebulizer. So there's several different ways in which we can administer the same exact medication. Okay, so that's what this is looking at. We do have syrup options. That's the one that I see used more often. Don't really see tablets used very often in these. So this is just a summary slide for you to see, hey, what are all of the things that I have that are available for me to use in my patients? And again, this will overlap as well a little bit when we talk about our asthma. Okay, so a bronchodilator. Bronchodilates are trying to do exactly that. They're trying to dilate what's happening in that person's lungs, because I told you that they have restricted airflow. So if I have, that does not sound fantastic. Oopsies. You tried to be slick, it just didn't work. Oh, that sounds like a mess. Okay, so with our bronchodilator, what we're trying to do is dilate the bronchioles, right? I want them to be as open as they can possibly be, because if I talk about COPD where they have limited airflow, if I talk about asthma where they're having a bronchospasm and things are tightening up, I'm trying to dilate it so that it can calm down so that my person can increase the amount of airflow that they have, which is being restricted. So again, paying attention to where you're looking is important, because this is our drug class, right? It's a bronchodilator, but I have several different things that fall under the classification of a bronchodilator. So my beta agonists, my anticholinergics, or if I take both of these things and I pair them together into that one device, bronchodilation is what's happening, okay? You see that this helps a lot with the symptoms, especially if somebody is saying that they are having an exacerbation. We go to a lot of these, especially our short-acting meds. So very, very good medications. Usually these are always going to be on board with our patients. So looking at our mechanisms of action, these are the two main things that we were talking about that we have, right? We had our beta agonists and we have our anticholinergics, and then we have the combo where I can put both of these together. Make sure that you're looking at your mechanisms, right? So this is going to increase the amount of CAMP or cyclic AMP, and then that is going to cause the smooth muscle to relax, right? And then if I can relax, now I can open up, all right? So that is why you see the bronchodilation, is because of the increase in the cyclic AMP. Remember when we talked about our beta-2 receptors and where they were? That was the lungs, so that's why we have the bronchodilation. When you look at your anticholinergics, looking at this, this is just trying to, again, decrease the amount of stimulation that we are going to have that's causing all of that tightness to occur. So if I block the stimulation of those receptors by that acetylcholine, which is the same mechanism that we've always heard, then I can get some of that bronchoconstriction to kind of calm down. I don't have it as much. So then again, my end result is going to be that I have bronchodilation, okay? And then looking at this, don't worry so much about that. Focus on my bolds, and you'll be able to, if there's a question about a mechanism, be able to answer the mechanism. Okay, so looking at your beta-2 agonists, we have our SABAs and our LABAs, right? So short and long acting. You'll hear people refer to them this way, but you can also just say the whole thing if you want to, right? So when I'm looking at the difference between these, they have different indications in which you're likely to see them used. When you talk about your SABA, think about it as being something that's very quick, right? So if somebody has an exacerbation, then I can give them a SABA and it will help relieve that asthma attack that they're having, or if they have COPD and they're experiencing extreme chest tightness at that time because of their lungs, right? They're not able to get that airflow, their lungs aren't moving the same way. Now I can go ahead and say, all right, let me give them a SABA, and what I should see is that cyclic AMP has now relaxed their smooth muscle, and now I can increase that amount of airflow that patient has coming in. So relief of acute symptoms, very quick onset is your SABAs. when you look at your long acting are usually on more so for like maintenance and trying to control those symptoms. We usually will have something else on board with our LABAs to kind of help in COPD and in asthma. So this holds true for both of them. You do see that when you add a LABA with an inhaled corticosteroid, that increases the efficacy of either of those drugs being used alone. This sounds kind of familiar to what we were talking about in the last lecture. When we couple things together, usually we're hitting it from two different pathways, and that's why we're getting that increased response. You do see that there's a black box warning when we're talking about our LABAs, especially if somebody is trying to use it in conjunction with if they're having an asthma attack and they're trying to use a LABA for the asthma attack. Some of these do have very quick onsets, but they're not FDA approved to use for an exacerbation in COPD or in asthma. So you should never see somebody using this to relieve an exacerbation. They should always be using a SABA to relieve their exacerbation, okay? So think about your LABA as it's taking too long. And if I can't breathe, do I want to wait a long time or do I want to wait a short time? I want to wait a short time before my meds are working, okay? So if that's your exacerbation, this is you using your SABA. With that, the more that I use my SABA, the more you should be worried about me and saying, do I have her controlled on her maintenance medications? Because why does she keep having to use this rescue inhaler? Why does she keep having these exacerbations? Is her COPD managed? Is her asthma managed? Because if not, maybe I need to increase the dose of something else or add on something to actually manage her. So we usually try to tell people to log how often they're using it. So when they have an inhaler, it does have a little counter on the back. They come with 200 inhalations per little canister that they get. But we do say like, hey, just write it down so I can see how much you're using it. Sometimes they may not be able to be like, oh, I used it 10 times, but they'll say like, oh, I've been using it a lot more now. That is your hint that, okay, ask them what has changed, what do you need to do to like make sure that they're well managed, okay? And then our products that we have here, you have your albuterol, this is the more common one that you're gonna see prescribed, and you have your levalbuterol, which is just a different form of your albuterol, less side effects whenever we're looking at our levalbuterol. Most of the time, this costs a little bit more than your albuterol, so if you do have somebody who's worried about insurance, then you like your albuterol. It's pretty cheap. Looking at your other LABAs that you have, I think about it as SOFA, right? So salmeterol, olidaterol, formoterol, and afrometerol. And then your ultra long-lasting options that you have, meaning these they can probably just take once a day, versus some of these that they may have to take twice a day. This they can just take once a day, and then this is your indapterol. So as long as you remember indapterol, that's good enough. You'll know that that's your ultra long acting, okay? So I like to be on the sofa for a long time, okay? iSofa. Put me on the sofa, okay? Those are your LABAs. This we'll kind of get into a little bit more whenever you're looking at your maintenance. Again, that's where you'll see a lot of the times where we'll have our LABA on board for that. These are the formulations and the abbreviations that you saw on that beginning chart. So when you see your hydrofluoroalkane inhaler, your dry powder inhaler, soft mist inhaler, and your nebulizer. When you see the FHA, this one is the one that's going to require coordination because they have to press down the canister. And when they press down the canister, that's whenever they're going to inhale the medication. So they have to be like, in sync, right? Hand-eye coordination has to work. Who do we think this might be difficult in? Kids, elderly patients, right? People who have some type of respiratory constriction as to why they can't breathe, the people that we're talking about, right? So sometimes we have what's called a spacer that we will add on to some of these to help kind of suspend the medication in a chamber. And then that way they can breathe in for a longer period of time and the med is still just in that chamber if they can't get the coordination down. So I kind of think of it as like a toilet paper tube because sometimes that's what you have to do if a patient doesn't have a spacer. You can take an inhaler and I put like saran wrap or something and cut a hole in it, and you can stick we'll have a picture of it, then you can stick the inhaler in there, and it just keeps the med there over their mouth for a longer period of time for them to breathe in, because they can't go and do it at one time, okay? Your dry powder. This one is the one that is a little more difficult, and this is the one that we will see a lot of patients come back into the hospital for because they have a DPI prescribed to them. A DPI, if I do not have enough strength or enough lung capacity to disturb the powder to forcibly get that into my mouth, the med is staying inside of the capsule. So this kind of looks like these. So what they do is it's like a little capsule in it, and when they move the mouthpiece, it pokes a hole in the capsule which has the powder in it. So they have to be able to inhale enough to get that powder into their mouth. If they can't do that, then they didn't get any med. Okay? This is how we see a lot of our exacerbations. They'll be on a DPI, but they can't breathe well enough to get the med into their body, so they keep having exacerbations. So you would just change the formulation that they're getting. Switch them to a HFA. You can also do an SMI. SMI, these cost a little bit more money. So again, if somebody is worried about like insurance type things, that's where you see this being a problem. Less coordination, because all they kind of have to do is twist it, but it is a different way that they're holding it, because this one is now horizontally. Instead of normally with an inhaler, you can just puff like this. That one, the SMIs are like long, and they just have a little twist thing on the end, so that's why it says it's less coordination. And then your nebulizer, if you ever prescribe anything in a nebulizer form, just make sure that you are also getting the nebulizer machine. We do not have those in the pharmacy. So if somebody does not have a nebulizer machine and you give them a nebulizer form of their medication, they can't take it, okay? So you have to go through write a prescription for a DME order, and then they will get that through the DME company, and then we can dispense the medication. So again, if you ever choose nebulizer, you need to make sure that you order a nebulizing machine. That does not come from the pharmacy. Okay, our drugs, we saw them, right? Here are your SABAs, here are your LABAs. These are the things these are your different formulations. Just know that different formulations exist. I am not gonna ask you, does it come in a solution or a tablet or any of that? I just want you to know what class they fall into. And then look at your comments. So remember I told you that your levalbuterol was a different form of your albuterol, but your albuterol is the one that is most likely going to be prescribed. Your levalbuterol is going to be for your patients who are very sensitive to albuterol, and we'll talk about some of those different adverse effects that they will have. So you can see less of that tachycardia, less of the tremors in some of your patients, especially if they're using it a lot. Again, we don't want them to use it a lot, but if they do, then we would be switching them to levalbuterol and trying to find a maintenance dose for them to not have to reach for that SABA very often. Yes?
For the nebulizers, since you said you have to order or prescribe the nebulizer machine, how long does it take for it to arrive when you drop using the formulation until that arrives?
So it depends on what medical company you go to. Some of them, they are horrible. It depends on the area that you're in. Sometimes you can also just get a prescription written for you, and you can go to a DME store yourself, like, and buy it. Depends on what's in the area. And then sometimes, like what I did, I just went to an urgent care and said that we needed one, and they have them at urgent care, so then they just bill TRICARE. So that's a way around it, because there are not a lot of places here that have like good DME stores. It takes forever here, like sometimes months. So yes, you would use something in the meantime. So like if it was a child, you could use one of your HFAs with a spacer, or just make sure that you prescribe a spacer. Some of the spacers come with masks that you can have, like little peds masks, and you can just put it over their nose. And so that way you're still doing the same thing. If you see that that's not working, then of course you can use a nebulizer. Most kids don't like to sit down for those nebulizers. So again, this straightforward. Just look at this. Don't try to remember all of the different formulations that you have, and then just paying attention to your comments. Also with your LABAs, because they last for a longer period of time, now I'm letting my patient sleep for a longer period of time. So if somebody is complaining of a lot of like nocturnal wakening because of their airflow constriction, then you can see that these are used for that. It's very useful, especially if they have those asthma attacks at night. And then again, not for exacerbations. You'll also see that your alpramortarol here and your indactorol here are specifically for COPD. And then your indactorol is the one that I told you was your ultra long acting. That was the one that we could see that we could dose once a day. So this is the only one that we have that we could dose once a day. Okay, mechanism of action again, we already saw this, so this is the same exact mechanism of action that you saw before. Essentially what it's trying to do is say, hey, let me relax the smooth muscle, let me relax the bronchioles, so that way I can then have increased airflow and hopefully decrease how much inflammation we have coming into the area, so that's the inhibition of the mast cell mediator release, okay? And then you see we have several different uses: asthma, COPD, hyperkalemia. You'll see us sometimes try to give one of our beta agonists, most of the time through an inhaled formulation. In the hospital setting, we'll nebulize it, and you'll see where this will then try to push the potassium back into the cell. If you see this happening, that's one of the other uses of our beta-2 agonists. Adverse effects. Same things that we saw last semester are here again, right? So kind of speeding things up. The tachycardia, the tremors, those things that you're more likely to see if they're using their SABA a lot. You're going to see more systemic exposure. So that is why these are listed here. But you also have hyperglycemia, hypokalemia. So remember with the hyperkalemia, that's why we're using it. We're using this drug for the benefit of that side effect. You see upper respiratory tract infections. You'll have several different infections that can occur, especially if they don't wash their mouthpiece. This isn't to prevent like thrush or anything like that, but if I throw it in my backpack or I just have it hanging out and I'm taking something that's dirty and I'm putting it in my mouth, you can see where you can have a lot of those respiratory tract infections. QT prolongation, this is going to be in overdose situations. We don't really see this happening a lot from like our inhalers. And then again, that black box warning that I told you about, specifically dealing with the LABA of us seeing that occur. Your interactions, again, additive effects that you'll see if you have any type of other adrenergic medication, because these are beta agonists. So if I give any other agonist, now I have those additive effects, so I'm more likely to see a lot of these side effects occur, these first ones up here. And then if I have a beta blocker on board, I could be potentially blunting the response that I'm getting from my beta agonist, especially if it's one of the ones that are non-selective, right? Because now I'm just all over the place. I'm not beta-1 selective. I'm non-selective, and so I'm hitting everything. So I could be potentially blocking my beta-2 agonist from working. And then you see that it can be safe in pregnancy. So when you're looking at this, just make sure that you're understanding that you can have a patient who has diabetes, who has any of these other types of conditions that are listed here, but you're just monitoring them to make sure that they're not getting outside of their managed range, okay? You might have to increase a dose. You might have to alter some type of medication that they're already on for that condition. Your anticholinergic bronchodilator. So when we're looking at this, mechanism of action is the same one that you saw in that first slide, just listed here again so that you can see it. Again, paying attention to the bold. You see that it lasts longer than our beta agonist, but the issue is that it takes a long time for the onset. So if I can't breathe, remember I want things that are going to work a little bit sooner rather than later. So that's why you'll see that we usually will use these in conjunction with each other. So our SAMAs that we have our epitropium, and then everything else is a LAMA. So your aclidinium, your glycopyrronium, tiotropium, and umeclidinium are all different options that we have available. So again, just know that these are all LAMAs, and know that this is a SAMA. I don't need you to remember how it is the formulation. Okay, hypertropium, again, SAMA classification, your clinical use, just using it for your patient who has COPD. We'll talk about this also, again, whenever we talk about asthma. You saw us use it when we just talked about our rhinitis, we had the nasal formulation as well. Looking at your pregnancy, okay for the most part. Adverse effects are anticholinergic adverse effects, so just drying everything up like we always talk about. Again, you're more likely to see this if they are having a higher dose most of the time because it's going to the site that we want it to go to. It's going to the lungs. We don't have a lot of systemic adverse effects. And then you see also your bronchospasm that could potentially happen, not something that is very common, but is a good drug for us to use, especially in our patients with COPD. Looking at your tiotropium or your LAMA. So thinking about this, again, most of the time our patients will take this one twice a day, but you can have some of your patients who are well managed with just that once a day option. But we do have a majority again on the twice a day. You see that I am not using this because it is a long acting. I'm not using this for any type of exacerbation. And then I am going to take this every single day because this is a staple that we have in our patients who have COPD. So this is like a part of their backbone. This is a must that they are having this, okay? And then pregnancy, we don't know. We could potentially have someone who is pregnant taking it. We don't have enough data. And then the side effects, same things that we talked about on the previous slide, interactions make sense. Biggest thing that you'll see complained about here is going to be the dry mouth that patients will get, right? Because it's right there in their mouth where they're using that inhaler. So the anticholinergic effect that is more common is your dry mouth. This is just showing you how you can have your SABA combined with your SAMA and your LABA combined with your LAMA. So essentially I'm trying to use that beta agonist in conjunction with my anticholinergics that we just talked about here, right? So now I just put them so that they're one inhaler. I don't have to have them have two different inhalers. So albuterol with your ipratropium, and then you have all of these different combos that you have with your LAMAs. Okay, so just know that there are combinations, and it's helping us with our adherence because we have two of those meds in one inhaler instead of them having two. All right, our inhaled corticosteroids. So when we look at this, these, again, we like steroids, they work, we don't love their adverse effects. So these are going to be more so saved and reserved for our patients who are more severe and we're not controlling them on that LABA or LAMA type drug regimen. Also, we can use these if a patient has increased eosinophils, or the corticosteroid can kind of help target that as well. So looking at this, you see that I'm increasing several different types of infections, pneumonia, thrush. I can have different issues occur with my patient's voice from using these for a very long time. Depending on how long they're using the steroid, once they try to stop it, I can have potentially HPA axis suppression that occurs. So then I have to taper them off of it, and I can't just stop them off of it. So there's several different things that kind of come into play whenever you're looking at this. What the big thing is that you don't see, like we saw with some of our other meds, is that they're not going to help with that FEV or mortality. And that's what we're looking for in these patients, because remember, this is a progressive thing that's happening in our COPD patients. We're not getting any benefit when we're using our steroids. In that situation, all we're doing is getting symptomatic relief because they're not responding to the two previous drug classes that we just talked about, okay? So this is like your last line reserved for your person who is like, hey, nothing else is working, right? Because I don't want to expose them to that steroid consistently. Now, when I do give that inhaled corticosteroid with that LABA, because let's say historically my person or their disease has progressed and they're not responding to the LABA-LAMA combination, what I could do is I give them this combination, and it may have a lower dose of a steroid, especially if they're taking it and having to use that every single day, okay? So again, we already talked about how it's more effective than us using each of them separately. And then we see a lot of those exacerbations hopefully being decreased because, bless you, I have decreased the amount of inflammation. So if I have less inflammation, which is what my steroids do, then I have less exacerbations or less airflow restriction, okay? Because I have tried to stop how much swelling is around in that area, because that's what my mechanism of action is for my steroids. Big thing with this is that you see that they have to rinse out their mouthpiece. So again, there's like a canister, like an aluminum canister that will have the medication in it, and then they have a plastic mouthpiece that they'll stick that canister in. Whenever they do that, that plastic mouthpiece, you can always disconnect the canister and wash it off. Same thing if they were using a spacer. They can also clean off that spacer, rinse it out, wash it soap and water, because if they don't, you'll see that they have the increased risk of them having the candidiasis or thrush that we can build up on their tongue, because they're not rinsing out their mouth afterwards and they're not rinsing off that mouthpiece afterwards. So those are two things that have to happen, mouth and the mouthpiece, okay? So both things to avoid the fungal infection that they could get. If this does happen, first semester type thing or last semester type thing, you would just treat the antifungal infection. That's all you need to know, is that you would treat the antifungal infection. I don't usually know what you would be treating the antifungal infection with, okay? All right, again, just the combos that you see with the LABA and your inhaled corticosteroid together here. So just make it more beneficial for your patient. Some of the other medications that we have, we can put our patient on oxygen. That's all you need to know about oxygen. You don't need to know anything else. Y'all will learn that whenever you're in home. Just know that that is an option. So you'll see some of your patients who have COPD, they'll be on oxygen, they'll take their oxygen off to go and smoke their cigarette. Like that's these people, okay? My best friend's mom does that. I'm like, oh, okay. Your theophylline, this is the one I told you we don't use as much anymore. What's different about this is this one is a capsule, so it's not an inhaler like we typically were seeing with all of our other meds that we were using. So you see it's like it's methylxanthine, which is something that's kind of similar to caffeine, and so we're using it to kind of get that effect for the patient. Like I said before, a long time ago, we used to use this a lot. Now we don't really use it as much, so that's why you see that's never a first line therapy for one of our patients. You see your mechanism of action, again, inhibiting that PDE 3 and 4. Some of our other meds that we'll look at, they're specifically just going to target 4. So when you see that, what it's going to do is it's going to cause that smooth muscle relaxation to occur, and therefore now I can breathe a little bit better. Okay, so the end result is always the same. So you see some different pros here is that, like, when we compared it in the studies before, it was better than placebo, but you also see that there's lots of bad things that aren't fantastic, right? Narrow therapeutic window drugs, we don't really like them because that means more monitoring, more counseling, more following up that I have to do with my patient. Convulsions and arrhythmias as a side effect, no thank you. And then you see that there's different evidence that say what helps and what doesn't help. So again, last line type of medication, be aware that it exists, because you will see some people who still have this prescribed to their patients, but just not commonly at all. Your phosphodiesterase 4 inhibitors. So you have your roflumilast. Again, what's different about this one is that it's an oral formulation, again, as in you're using a tablet, okay? So that's what this picture is down there to help you remember it's not an inhaler like everything else but a tablet. And then in its name, PDE4 inhibitor, what it is doing is decreasing the inflammation by stopping that PDE4, which is along that cascade that we saw in the last lecture with our allergies. Also, keeping the camp around for a little bit longer. And we already said that our camp increases the smooth muscle relaxation. So if I don't allow it to get degraded, I'm indirectly causing that smooth muscle relaxation to continue to occur, because my camp now has a longer half-life. So with that, indirectly, right, no direct bronchodilator activity. It's helping with the camp. Looking at your contraindications, if someone is breastfeeding or if they have any type of liver issues, we're not going to give this to them. So if you remember liver and lactation, it's a no. And then your clinical use, again, these are your patients who are having these exacerbations that are pretty bad to where they could potentially end up in the hospital, like you're moderate to severe, and you tried them with a steroid or anything like that, and maybe it's not working, or maybe they keep having that steroid exposure frequently, you don't want to do that, right, because of the side effects. So this is a different option for us to have that's steroid sparing in a way. And then you see the limited role whenever we're talking about our severe patients. If they are mild to moderate, we don't see a lot of benefit, just more cost for the patient. So make sure if you're using this is one of your more severe patients who hasn't responded to other things, or they have had a lot of steroid exposure, and now you're needing to give them something else to help them with their exacerbation. Adverse effects, pretty standard. I kind of link these two things together. If I'm not eating a lot, then I probably will lose weight. Sleep disturbances, if I also am going to the bathroom all the time or throwing up, probably all of that is tied to weight loss in my brain. Okay? The only thing that's weird is the sleep disturbances. Okay? I'm not sleeping because I'm so skinny. And then your caution. So in your patients who have depression, we have a caution here because it can increase those thoughts again. Also think about, like, if I'm not sleeping and I'm tired and everything, then kind of starts to become a problem. So it kind of stacks on. So just caution in those patients, check on them, ask them those questions whenever they come in for their visit. Not an absolute that you don't have to. Okay, watching out with our CYP inducers as well as our inhibitors. On that, just understand inducer, inhibitor, you'll be fine. If I give you one of them, I'll tell you if it is an inducer or an inhibitor so you know what's going on. Other things that they should be doing is getting vaccinated, right? These are now becoming difficult conversations because everybody doesn't want to get vaccinated anymore. When we don't get vaccinated, what comes back? All these different infections that we thought that we got rid of, okay? So flu vaccine, COVID vaccine, pneumococcal, basic things. You should not always need to use an antibiotic. It just depends on why that patient is having their exacerbation in COPD. If it is a bug that is causing them to have that exacerbation and to be sick, then of course we treat the bug. If it's not the cause, then there's nothing that we're going to be doing, okay? Also, if they're having a lot of exacerbations and they've been on a lot of antibiotics, you're increasing resistance, okay? So just make sure that you're using it if it is indicated. If it's not indicated, we don't need it. All right, these are our guidelines. So we talked about the drugs that we would use in COPD. Now we're looking at Gina Gold. This is an actual link that you should be able to click on, and it'll take you to the guidelines. But it's this really long, global, essentially, initiative on how to treat asthma. They have one on how to treat COPD. So you have A as your group. So group A, group B, and group E. So the way that you're looking at this is this will depend on what you're looking at. So your test is a little more behind, like when you guys take the PANTS. So you could be tested on this in two different ways. So it just depends. By the time y'all get there, you'll be tested on this chart. There is a 2025 chart that is a little bit different. So for our exam, we're going to stick to this one. So what this is saying is if they had over 2 exacerbations, so this is exacerbations that they're having, and then these are the scales that they're having to assess the severity. Remember the ones that I showed you at the very beginning to say, like, do they have a lot of symptoms? Can they get up and walk and move around? That's what these are, okay? So your MMRC and your CAT score. So you would have a CAT score from your patient, you would have an or an MMRC. Sometimes you may have both, sometimes you might only have one, and then you're gonna put them in a group. So if I had less than 0 or 1 moderate exacerbations, I did not get admitted into the hospital, I can be in group A or group B. If I'm group A, you can use any bronchodilator that you want. So that's a SABA, a SAMA, a LABA, or a LAMA. I can use any bronchodilator that I want. Doesn't matter, okay? If I am in group B, you see my scores are worse. My MMRC is higher, my MCAT is higher. Don't need you to remember what they are, but I'm differentiating between group A and group B. This patient, they're gonna give them a LABA and a LAMA, okay? When I look at group B, this person has gone to the hospital at least one time, or they've had more than 2 exacerbations, right? So this is that person who's not very well controlled. So I still will treat them with a LABA or a LAMA, just like I did with group B. The only difference that I could potentially see in my group E person that if they have those eosinophils over 100, I add my corticosteroid. And remember that was on that slide where it said you could potentially have to use the inhaled corticosteroid if those eosinophil levels were high. Eosinophils are present whenever we look at some of our exacerbations. So test-wise, you would be told what group a person is in, and then you have to figure out how you're going to treat them. Am I using a LABA and a LAMA, or do I get to pick any bronchodilator? When do I add on a steroid? That's the only thing that you're looking at from this slide, okay? So LABA, LAMA, same thing. Differentiator here is, do they have the eosinophils over 300, which makes me add my inhaled corticosteroid. And then here, group A, they're the mildest person, right? They're not having any hospitalizations, they're okay. I can pick any of my bronchodilators that I want, okay? So anything that I want to use here, LABA, LAMA, LABA, LAMA, high eosinophils, add on a steroid in my group E. So A, B, E, okay? Yeah? Some of y'all are asleep. Got it? Okay, so my initial treatment. I'm talking about my patient with COPD. I have my short acting that's going to be for my exacerbation, so like the thing that I need immediate relief on, right? I don't want to be able to not breathe for a very long period of time. So that's why you have your short acting or your SABA on board. It should always be there. When you have your group A, this is just a summary of what you just saw on the previous chart. So I can use my SABA, I can use my LABA, and then I can use a bronchodilator. Any one doesn't matter. I can also use my LAMA or my LABA. My LAMA or my SAMA, okay? So it doesn't matter. Any bronchodilator will work in group A. When you look at group B, LABA, LAMA. Group E was the one where your eosinophils mattered. If they're over 300, adding your steroid, okay? So consider your triple if you had to. With this goes into the costs and the things that I was telling you about before. Your long-acting anything does cost a little bit more because it's coming with the convenience of them not having to take it as often. But if you have a patient who is not experiencing a lot of exacerbations, then you can, if your patient is experiencing a lot of exacerbations, then you would probably want to put them on a LABA because it's going to last for a longer period of time. If your person is just having those exacerbations every now and then, your short-acting are better and they're cheaper. They don't need to reach for it for a long time, okay? So that's what this is saying. Long-acting is preferred, except in your patient where they're not having a lot of breathlessness, okay? It's very rare that they're having breathlessness. So in that case, they shouldn't be reaching for anything for a long period of time. All right, so your challenge question, 65-year-old comes to the clinic, he smokes 4 packs a day, smoked for a very long time, he has a cough, he has to stop for breath after walking for a short period of time, he's in class C, he already has his SABA for his rescue inhaler, he's in class E, what things should we be having on for this patient who is in class E? What 2 things, based off of that chart that we looked at, what 2 things should we have on board? A LABA and a LAMA, right? So, which one has a LABA and a LAMA? Right here, B, right? What class does this fall into? Antisoda. So, yes, so make sure that you're paying attention, right, to what is your chart showing you, and then making sure that you understand, like in that very long beginning one that I showed you guys, like what drug falls into what class, okay? The chart is not the hard part, it's the remembering which drug goes to which classification, okay? So if you remember that, that also helps you when you go through your asthma, because your asthma has the same exact LABA, LAMA, SABA, SAMAs. Okay, so there's just 2 that you don't use in asthma, but it's the same exact drugs that we're going to talk about the second half. Okay, so now we're looking at asthma. When you look at asthma, essentially the big difference here between the COPD and the asthma is that this is going to be more easily reversed whenever I give my treatment. Okay, so if I give my inhaler then I can easily say, hey, let me decrease that excess response or that hyper-responsiveness that my patient is experiencing that's causing that bronchoconstriction and a limited airflow. Okay, so this is showing you what a normal airway looks like, and this is what happens when somebody is having an asthma attack. They have that spasm, and so our meds are trying to go in here, relax it so that I can open back up my airway again. And you will see a very quick response, especially if you're using a short-acting medication with this return to that normal airflow. Okay. These are just some of the symptoms that you will see. Just understand our drugs are trying to help with the symptoms. I will tell you what's going on with your patient, if they have asthma or if they have COPD. Sorry, let me go back to this. The only thing that I want you guys to understand here, your patients who have asthma, if they get sick or they're going and they're working out, they're running, they're doing something that causes them to have a decrease in their airflow, you're more likely to see, of course, them be triggered and have an exacerbation, which then they would need their inhaler to help them through that exacerbation, okay? So things that seem very normal, remember how I was telling you guys about the different types of allergens that we could typically just see around that people have like allergic rhinitis to? These are things that can also cause asthma, so that's why most of the time you'll see them have asthma as well as allergies as well as like some type of skin or eczema type of thing. They're all in the same pathway. So, beta-2 agonists and allergies, same thing that we already saw, okay? Same drug, same everything. This is your SABA and your LABAs, same things that we talked about before. When you're looking at your SABA, again, the more I pick it up, the more that means that I'm using it, which means I might not be very well controlled, and I need you to get me on some better maintenance therapy that I can take every single day, because I should not be reaching for this SABA every single day. That's not typically what we would use it for. We don't like it for that. When we talk about these SABAs, they are great. Exacerbation is where your mind should go, but we have several other drugs that we would want our asthmatic patient who has a lot of exacerbations. We have better medications to put them on, okay? So don't think of this as like, cool, just use it every single day. Just use it as much as they need to. This is not what we want them to do with this, okay? Your LABA, again, we talked about these, slower onset, don't use them in an exacerbation. Make sure that you're remembering which products go into that. Now remember, your indacterol and your alpramoterol are not going to be on there. Those are for your COPD only. So you have your salmeterol and your formoterol here in your asthma patients. Again, don't worry about this. You see that they have rapid onsets, but that's irrelevant to the fact of us using it in an exacerbation. So I don't even want your brain to think about like, oh, you're going to see a short half-life or you're going to see a rapid onset and think I can use it in an exacerbation. Not using it in an exacerbation is not FDA approved to use them in an exacerbation. What was my black box warning for that? Increased risk of death in our asthmatic patients, especially if they're during the time that they're having an exacerbation, because they will reach for their LABA and it's going to take too long for it to work. And then they're dying because they can't breathe. Okay? We'll start here when we come back from our break.
Yeah, quite the setup, you too. Huh? I bought you still sitting on me? I bought you your fan. I literally bought her fan. I bought one tonight. I bought one for I bought one and I was like, hey, you want it too? I bought him. So I bought it too. Well then we went over to her. Tatum's like, oh, this is cool. So then I bought one for Tatum, and Casey goes, wow, you're buying one for everyone, but you don't want to buy one for me. I was like, okay, I'll buy you one too. Well, discount if you thought ahead. They were like $12. Yeah, like the turbo. Oh, it was good. And so people
qualify and get to the thing first, they'll have more time to charge the turbos. Whereas people in the back, they just get there and then the lights already start going. They have less time to start the turbos. Trying to have them start at the same time. Some cars they don't have the lights, so it's going to take really long to get the turbo charged. So some cars will be able to just rocket ship, take places in the beginning. Some of them, even though they're all in the front because they got fast cars, they're going to be spots. No, it's yes, it's the dimension, what it's supposed to do, but how they made it is completely different. That's the thing with Formula 1. It's like science or project. Who creates the best? Who's more innovative? Exactly, but yeah, everybody's trying to find little loopholes. Like the engineers are trying to find loopholes. Like, oh well, they didn't clarify how much fuel is supposed to go into where the engine's supposed to fire. This doesn't say like how many volts it's supposed to go. The whole point. Oh yeah. Yeah, no, but that's the reason why. You know, it just took forever to happen. And you know, like, now we have a reason to do it. So it's kind of funny. Just no, but we all like it. It sucks that he did that. No, dude, I saw that. Yeah.
Basic. On the gas station. Did I tell you that? I told you. I know I told you the other day. My watch set off on Apple. Figured it out. Please.
I thought you put this
I
here
did it the next day too.
No.
Shortly after that, it was like,
You're like
heart rate.
down.
I think it knows that I'm like sitting and not doing shit. And then it's like, yo, your heart rate's like up.
You're just not paying attention at all.
No, I'm still making it.
It does help.
Yeah, it's a nervous system.
So when I'm sitting there and falling asleep, that's a future.
Yeah.
I've sat there and been like, I should stop.
It's either that or I fall asleep in my chair. So.
You get brain fog when you stop taking them, and I'm like, I can't afford to have brain fog right now.
For a problem.
I can't do it.
I can quit whenever I want. I just don't.
It's not me addicted to the nicotine. It's nicotine.
Because it needs me, and who am I to say that?
Exactly. I don't want to be just.
Deny it what it wants.
I don't know.
It's like the old drinking for good. Drink free fuel.
Yeah. One Scott says, I don't drink anymore. I just don't drink any less.
Yeah. Legit, especially if you try to bet 250 ways, you know, that would come.
Oh yeah, that's.
Oh, damn it.
Like actually color, or is it just like no? It's an end of I have to pay attention because it's like first pass.
I thought that was you. I won't.
Oh, I know, but I'm making like associations with my kids so that when I actually do study, I do it again, the same association. It's doing it. And then I'm like,
I was like, who is this guy? That's why I have to study. Because I just make notes. I don't really.
like when we did our study group passes, I went home and I studied.
No. Yeah, the kid.
The same thing, right?
I'm just telling you.
Right? She already talked about it. So is this different? She said, don't worry about this, that, but then she notes out, normal is this, and then
Need that lava lava.
she already said that.
Lava lava ice.
Or am I reading it wrong? It's the same thing, right? It seems like she was trying to make two different points, but like, they were the same.
How much I want But I sent my class. We're there on one device with all of them, but they used to lug around so much, so the same got
It's the first thing you need to be professional. Wouldn't that be perfect? Everybody listens. He wouldn't have went. And then the coach, you don't go.
Jordan's never had sciatica. Oh.
All right, let's pick back up. Looking at our steroids. So when y'all are studying this, honestly, just you see how easy it will be to kind of go through it, right? So you can literally just write the drug classes that you have. Can I use this in COPD? Can I use it in asthma? Which one is preferred as a backbone thing in COPD versus which ones are preferred as like the backbone in asthma, it's all the same drugs that keep coming up, right? So they're the same exact drugs, same exact mechanisms, you're using them similarly, okay? Not always exactly the same. All right, so your corticosteroids, again, same thing that we talked about before, but now whenever we're looking at this, again, we're trying to say, hey, I have these steroids, I can put them on board, not only do they help me with that acute phase, but they can help me with that late phase that's happening as well. And I'm trying to decrease the amount of inflammation because that is my problem that I'm having in my asthmatic patients. You see that we have a great benefit here because it can reverse the airway remodeling. In our COPD patient, once they have that remodeling, most of the time they're stuck with it, which is why that disease kind of progresses because they increase that amount of airflow limitation along the way because they have remodeling. With our asthma patients, it's more so reversible and therefore they're not stuck that way. And if I use a steroid, I can see that I can decrease that remodeling. Does that mean that I have this on board all the time? No, because remember, this is a nasty drug. It's a great drug, but it's a nasty drug as far as the adverse effects. And the longer that I have somebody on it, the more likely I am to see them have those adverse effects. So when I'm looking at this, you see my moderate or severe exacerbation. Okay, if somebody is having an exacerbation, I put on a steroid. Depending on how bad that exacerbation is, I can try to start topically or start with an inhaler and then progress to where I'm having to use an oral burst of the steroid, okay? So it doesn't necessarily mean that it always has to be an oral. It could be an inhaled form as well. So moderate to severe exacerbation that a patient is having, and if I'm trying to say, hey, I want to decrease the amount of exacerbations that they're having, or they were having an exacerbation, I gave them a SABA to kind of help relieve that exacerbation, but then they relapsed and their exacerbation came back, okay? So this is also helping kind of decrease that if you know that your patient has a history of, I give them a SABA or I give them an inhaled corticosteroid, it helps reverse it. But as soon as I do that, now I've kind of caused them to have, they had a quick relapse after I did that. You'll also see us put those steroids on board. This is telling you that your oral is going to be systemic. It's usually a burst. Most of the time, on average, you'll see a 7-day burst being used. You can have some patients who are hospitalized a lot because of their exacerbations, where we may put them on that 10-day burst of the steroid. But again, this is just to try to help us hurry up, decrease that inflammation, so that patient can then be discharged from the hospital, and we can discharge them with this because it is just a pill that we're going to send them home with. When we're looking at this long-term oral, if we're getting to this point, you're going to have already referred them because, again, those side effects are not fantastic. They're not great side effects, and we don't want a patient on a steroid for a very long period of time. So if they are having those severe symptoms, it is possible for you to see them on lower doses, but again, if they're on a low dose for a long period of time, you can still see a lot of those side effects that we're going to talk about coming up here. Pay attention to the different ways, right? So this one is inhaled versus your systemic. So when you're looking at your inhaled, you see that this is one of the first line meds that we'll have on board for our patients. So mild all the way up to your severe patient. If somebody has an asthma attack, you can also see where we'll try to start with that inhaled before we give them the systemic. If they don't respond to the inhaled, then we will try to give them that systemic or the oral formulation of that steroid. You see that I have my great anti-inflammatory effects that are going to be coming from it, and it shouldn't be used alone. We're going to talk about this. When you look at using some of our inhaled corticosteroids, most of the time we'll put it with another agent because, again, we know that those combination drugs are going to give us a better response and increase our efficacy than using one alone. But sometimes whenever when you'll see when we look at our GINA chart, you can see where sometimes this is also used as a rescue inhaler in some of our patients. Your systemic corticosteroids, again, this is for your more severe patient, your patient who is not responding to that inhaled option. So that is going to probably make them be more severe. They will likely be hospitalized because most of the time we don't just prescribe our patients steroids to have just in case. You could potentially do that if you had a patient who was like a repeat offender, right, of having a lot of exacerbations that were making them end up going to the hospital. But sometimes with those patients, what we end up doing are IV steroids and not the oral ones because they are having trouble breathing. Sometimes they can't even swallow pills, so we have to give them the IV formulation of a steroid. So that's also another form that you'll see of your systemic. So then again, you have your PO, prednisone and prednisolone, and then your IV, which is your methylprednisolone. Pay attention to which one is PO versus which one is IV because depending on the situation, one could be preferred over the other, right? If I can't swallow one of these, then clearly you're not going to give me prednisolone, you're going to give me the methylprednisolone, okay? So paying attention to that. You see that I'm getting a quick response, right? Especially if I have that IV on board because I'm going straight into the system and I'm getting great bioavailability. So this is a very, very fast response that you'll see. Most of the time when our patients get in the hospital and we're treating them with a burst because of an asthmatic flare or exacerbation, depends on how often they have them. Sometimes we can discharge the patient the same day. Sometimes they stay for a couple of days. Also depends on other comorbidities that they might have. Okay, so this kind of depends on how bad your patient is. They might have to stay in there for a little while to get loaded with some of these steroids before we send them on our way. Make sure that they don't have a relapse. Here are all of your inhaled corticosteroids that you have. Okay, so you have your beclomethasone, budesonide, ciclesonide, flunisolide, fluticasone, and then this is just a different way in which it's given, the DPI, and then your mometasone. You see here, I have low, medium, and high dosage ranges, okay? So I'm using the same inhaler, but the more frequently that I give it, and even sometimes on the strength, the varying strengths that you have, will indicate if it's a low dose, a medium dose, or a high dose. All I need you to know is that there are different doses. We'll remember other things about our steroids. I don't want you to remember that about these inhalers, okay? So there are several different ones that you can get, bless you. So this one is a 40, this one comes as a 40 and an 80 microgram. So on the boxes, it'll tell us the different strengths that we have, right? So you see that some of these, there's several different ways in which you can pick. So when you go into Genesis and you're ordering this, based off of the potency, like the dose that you want them to have, a low, medium, or a high, you can then say, okay, let me give them an 80 if they're on this side of the spectrum, because I don't want them to take a gazillion puffs over 40 microgram, right? So then this is where this strength comes into play. For the exam, know what is an inhaled corticosteroid, know that you have low, medium, and high doses. Yes? Yeah, and we're not doing that. Y'all will get that somewhere else. Hopefully they don't come into your office. But yes, the doses are sometimes, because remember, what's a big side effect that I have with my inhaled corticosteroids in my kids? Well, yes, I could have that, but I have growth suppression too, right? The more that they're using it, the higher that dose is for that patient. So even my inhaled, my oral, any of those things can become a big issue for me. So this does change, and a lot of your algorithms for asthma change depending on the age of the child. So even the GINA guideline that we're going to look at, that's not the same exact thing for a kid. So they're based on their ages. Adverse effects, again, we see the thrush, we see the cough. The spacer, if we're going to use the spacer, this of course helps that patient get more of the medication, make sure that they're washing their mouth, and they need to wash the device in which they got that medication delivered to them. So the plastic mouthpiece, the spacer, they need to wash both of those things so that they don't get the candidiasis. This is your oral option that we had available, as well as our IV option. So when you see your prednisone, your dexamethasone, these are oral options. Your methylprednisolone is IV only. Your dexamethasone also has an IV version. This is the strongest one, the strongest steroid that we have. I'm sure maybe when we get to steroids, I don't remember if I have y'all remember, there's like dose equivalencies that they usually will have on exams for you to know, because like you can't have a dexamethasone and think that you're going to give them the same dose as a prednisone. They all have different strengths, like equivalents to it, okay? So this one, again, just making sure that you understand that the longer that they're on it or the higher the dose that they are on, you will likely have to taper them off because of HbA axis suppression that will occur. Okay, your prednisolone, this one comes in a solution, so that's very good if you have a kiddo, right? Because they can't swallow pills, you don't have to crush it and have that gross taste that happens with them. They can just go ahead and have that suspension, so making sure that you're looking at that comment. We already talked about this, IV, clearly if you're getting an IV, you're in some type of inpatient setting. And then your dexamethasone, again, same thing that we were talking about before. It depends on how bad the patient is when they present. If they're still able to swallow a pill, then of course you can give them that tablet for them to swallow. They like the your dexamethasone because this one has a longer half-life. So in the ED, you're trying to get them in and get them out either back home or to a floor, okay? So that's why you see it's like the less frequent that I have to administer something, the better in that ED setting. So that's why you see that they like to use the dexamethasone. Adverse effects, very similar, but now on a more systemic level. This is the same slide that you guys saw when we talked about using steroids before with your short-term and your long-term adverse effects that can happen, okay? So short-term, just looking at the fact that their glucose levels may be altered, their mood could potentially be altered, their appetite, the weight gain, that cushingoid type of experience is what you're likely going to see on that short-term use. The long-term use or higher dose use, you will also see, again, more systemic, more dramatic effects. So the height, the growth suppression, again, with skin, there's lots of skin changes that can happen. So especially if somebody is older, you're more likely to see this, but you'll see where their skin starts to look thinner, they'll bruise a little bit easier. You can start to see their veins sometimes. People will get stretch marks, lots of things can kind of happen. So these are two things that you will see kind of come up. When you see long-term use, also think of a high dose, okay? And we're gonna have a lecture that's over just steroids anyway, so this will come back up again. So either way, it's fine. All right, our other medications that we have whenever we're looking at asthma. So again, when I combine these things, I'm expecting for us to get a better response, right? So I have my corticosteroid with my LABA, and this is just one of those things that you can see a patient having to take on a more consistent basis to help them decrease the amount of exacerbations, bless you, that they're experiencing. This is the different things that I was telling you. You'll have lots of different strengths. So when you go in to place your order as the provider, you're going to see several different strengths that pop up, and you're going to choose the correct one based off of if you want them to have a low, medium, or a high dose. Okay? So this will vary depending on what you're trying to get your patient to, the dose that you're wanting your patient to have. This again, with your exacerbations, clearly we're not going to use a LABA in our exacerbation, so that makes sense. And then understanding that same black box warning that followed the LABA, because that is a part of the composition of this inhaler, you still see that black box warning on there. So you see fluticasone, budesonide, betamethasone, fluticasone again, with either salmeterol, formoterol, and you have your bilanterol. This Brio is a newer one. Just if you see it in combo and you see that it ends in oral, like know that that's a part of that family. I don't need you to remember a whole lot about the Brio. It's expensive and we don't use it as much as we use a lot of the other ones. Your cromolyn. So again, we talked about this when we talked about our allergies, but now we're looking at it in the context of our asthma. So same exact mechanism that we're talking about, the mast cell stabilizers, helping potentially with some of the inflammation that patient may have as well is going to be a benefit that we see here. It is an alternative. It is not one of the ones that we like to see particularly often. More so for your patients who have mild asthma, so they're not having a lot of exacerbations and things like that, because this medication is not fantastic, right? So just think of this. Usually, so your mast cell stabilizer for your milder cases, but it's not first line, okay? You see long term, you already know when that exposure is happening, the same type of rules that we talked about before. Even when we talked about the effectiveness of this compared to our other options, we see that we don't we don't like it as much, okay? If somebody is having a lot of side effects to potentially that steroid that you're having them inhale, then this could be a potential option that you're using. But again, you're pushing this down to the back. You do see that we have a nebulizer option as well, so not just the inhaler. Your adverse effects, the same things that we are seeing in a lot of these other inhalers, right? So we have that cough, we have that taste that can come along with it. Your Xolair or your amelizumab, this one you see is getting a little more invasive. So now we have this injection that this person would be receiving. They would have to come in. We have seen, and I have seen where this medication is a very good one. I have not seen a primary care prescribe it. I haven't. Most of the time this is coming by way of the allergy clinic. So look at your mechanism, pay attention to what's involved to kind of key you in if you have a question about the mechanism of action. So binding to the IgE, which we know is a part of that inflammatory and that allergic response that we're going to have, and therefore it kind of helps decrease the amount of mediators that are going to be released from those mast cells and trying to help us not respond as dramatically as we would to whatever the allergen was. Your clinical use, so more so long-term, moderate to severe, right? They're not responding to some of those other medications that we have previously talked about. This is, again, down the line with you using it. Administered every 2 to 4 weeks. What happens is they'll go and they'll get labs depending on that person's IgE level that they have in their body. The higher it is, the more likely they are to have a larger dose to try to get that under control so that they don't have an increased amount of exacerbations. Adverse effects, that injection site is going to hurt, and potentially because you see it's a monoclonal antibody, right? It's a mAb, you see that you can have anaphylaxis that happens. Depending on what clinic you go to, will determine how long they keep you. Usually it's 30 minutes to an hour. They'll keep you afterwards to make sure that you don't have any type of response or anaphylaxis to that injection that they're giving you. Your leukotriene receptor antagonists, talked about these, right? But now you're actually seeing the Zophroleucus here. But again, the one that we prescribe more often than not is going to be your Singulair. Again, remember we could do that in the kids because we had those granules that we could use, and they also have that chewable tablet. The difference between these two when you're looking at these, right? My Montelukast came with that black box warning because it altered their mind, right? The neuropsychiatric disturbances that we had. My Zophroleucas, the reason why we don't see it used as much, one, it's an older age, but also you see that the bioavailability is decreased by food. So now I'm having to also tell my patient, oh, make sure that you're waiting an hour before, or wait an hour after you take it before you eat, or, you know, so it's not as clean of a drug, which is why it's not as popular as our Montelukast. But if we're worried about any of those psychiatric disturbances, this could be a good option if you did have to get down to that leukotriene antagonist. So clinical use, long-term, right, in our patients who have milder exacerbations that do happen, and then again, looking at the fact that you can use it in combination with your inhaled corticosteroid is another option. Adverse effects, we saw these. Most of the time it's okay. Biggest thing that you might hear about is a headache. That black box warning when we were talking about our Montelukast, same thing that's showing up for you again. With your Zophroleucas, I have to worry about the food with it, and I also have where I can have some of these hepatic issues occurring. So that's the post-marketing surveillance. So that's after the drug has been approved, it's on the market. Remember, we're always in like that post-marketing surveillance where we can report side effects as clinicians. You can go in and you say, hey, MedWatch, look at what's happening with this drug. They had a lot of those come in, and we saw that hepatitis and hepatic failure was sometimes happening and potentially also resulting in death in a bad situation. So if they're having any of those issues, of course we want to discontinue the med. How do you think we would know if they have those issues? What would you be monitoring? You see jaundice, LFTs, right? So like making sure that you're keeping an eye on what's happening for your patient. Get in that baseline and then do it again. Interactions, You remember that the Zarcolucas was the one that was giving us all of the bigger problems, right? So you're dealing with your inhibitors. Xylutin or Zyflow. This one is a little bit different too. Another oral. So all these ones that you see in our other section are where you start to hit oral things. So in the name, again, you have your mechanism of action. So inhibiting the leukotriene from your arachidonic acid. So again, this is that same pathway that we had before. So essentially what it's doing is it's saying, hey, if I can stop this from happening, right? I don't want to get to this. So it's trying to say, I don't want my arachidonic acid to even get down into this inflammation pathway, to get down into this bronchospasm pathway. So I'm trying to stop it right here, all right? So that's where you're seeing your mechanism of action. Again, in your milder patients, second line type of thing, not something that we would go to first. I see this very rarely being used. You can also combine this again with your inhaled corticosteroids, our interactions, increasing my anticoagulant effect of warfarin, which we know warfarin interacts with a lot of things, but essentially what you'll see is that increased bleed risk. Adverse effects, we talked about LFTs. This is another one with your LFTs, so you're going to have that increase, and then make sure that you're getting it at baseline and you're monitoring it while they're taking that medication. The longer you leave it on it, the more work. Leave them on that, the more work for you, right? And then you see the hepatitis and the hyperbilirubinemia that could potentially occur. So again, just think of it as being a system inhibitor and not a receptor antagonist, like we talked about with our leukotriene receptor antagonist, right? So not the same things. The names look very familiar when you're looking at these two things. Our anticholinergics that we have, okay, so this is looking at my SAMAs and my LAMAs. So I have my tiotropium, my ipratropium. When I look at this, mechanism of action is the same exact thing. If your patient is not very good with your SABAs, or if they're having to use their SABA a lot, you'll see where we'll sometimes have an anticholinergic also available for that patient. You see that you're using it in conjunction with one of your beta agonists, sometimes in a hospital setting. Just depends on when they told you they took their medication and what other regimen they're on. Some people will already be on regimens that have multiple, so they could have like a SABA and a SAMA. They could have inhaled corticosteroid on board. There's several different ways in which they could have their treatment. So just pay attention to, I have an anticholinergic, these are what they are. It's an alternative treatment, not a primary treatment that I would have my patient on, okay? You see that, again, something that's not used in my exercise-induced bronchospasm. So now I have two things that I could potentially use. I could use my SABA that we talked about, and I could also use one of my leukotrienes, right? My Singulair, I had that I could take that also prior to an exercise if I knew that I experienced frequently exercise-induced bronchospasm. So those are two options that we have. Adverse effects, again, because it's an anticholinergic, it's drying things up. So make sure that you're paying attention to that. It could potentially rebound and cause you to have more wheezing that happens. So just pay attention. Used in the ED, the idea behind this is that if somebody is very sensitive to that beta agonist and they have tachycardia, or if they recently just took a dose of it and it didn't work, that you could increase the risk of the tachycardia. So if I give them an anticholinergic, I'm less likely to experience that side effect occur in that patient. Okay, so that's what this is saying down here: less cardiac stimulation. Okay, so this is talking about what happens, and this is how you will assess your patient's severity of their asthma. If I look at this, right, I have intermittent, mild, persistent, moderate, and persistent severe. These are more severe. These are going to interfere with my patient's ADLs more than if I had somebody which is intermittent or mild. If my intermittent patient, they're not likely going to be using an inhaler a lot because they don't have anything happening to them on it. Like, it's very rare. Okay, so they're not reaching for an inhaler all the time because they're very intermittent, it's sporadic when these things are happening to them, or it could just be whenever they're exercising or something that's going on as to why they're having these flares. So getting a full understanding and a full picture of why your patient is presenting is going to be important for you to know which medication you're going to prescribe for them. So I will tell you what's going on, and you will say, they're well controlled, I don't need to do anything, or I need to increase what they're doing. So when I look at this, if I have a patient who is in any one of these categories, right, they're severe, this is telling you that they initially came to your clinic. So I came into your clinic and you pin me down to one of these categories, right, depending on what I have told you. Then you will say, okay, cool. You're a step 1 patient, you're a step 2 patient, you're a step 3 patient, you're a step 4 or 5 patient. This is where you're going to initially start me on the chart, okay? So like this is my first move, this is your first move as a provider to say, where does that patient go, all right? So I will tell you what's going on, so just be familiar that this thing exists. I don't need you to remember anything from this. Just know that it exists, okay? Now, your maintenance is a little bit different. If I tell you that your person is on whatever step that they're on, you're going to say, oh, well, this is probably what they're using, or this is what they're using. This is saying, I came back for my follow-up visit, and you're now trying to tell me if we need to change my regimen that I have, or if it's good enough, okay? So, well-controlled is saying, there's nothing wrong, right? I'm well-controlled. So then what do you need to do? Leave me where I am, because I am well-controlled, okay? So this makes sense. Your not well-controlled patient means that they might still be having exacerbations a little bit more than they should be, and so what you'll do is you'll increase them by 1 step, and then your very poorly controlled patient, you might have to step them up 1 or 2 steps depending on how much they're reaching. So remember, if your patient is well-controlled, leave them where they are, and if they are not well-controlled, then you're going to step them up 1. If they're very poorly controlled, then you might have to step them up 1 or 2, okay? Could potentially need steroids in this severe patient. That's all you need to know. I will tell you you don't need to worry about all of this. Just know well-controlled, not well-controlled, very poorly controlled, and what do you do? I don't need you to remember this. You're not telling me what they are. I will tell you what they are, okay? Everybody good? Don't try to remember all this because this doesn't matter. The middle doesn't matter. Just the outside. Okay, so this is the GINA guideline. So when you look at the GINA guidelines, this is essentially saying, hey, how do we want to treat our patient who has asthma? Where do we start them? What do we put them on? Things of that nature. There's 2 different tracks that you can see that are listed here. So your track 1, we like this because it's a cleaner regimen for our patient. It's giving them this 1 inhaler to typically have to reach for. Do I still prescribe them a SABA? Yes. Anybody who comes into you who has asthma, who has COPD, they will all have a SABA on board all the time, just in case stuff goes left, okay? So they will always have a SABA. The controversy behind this whole GINA versus different guidelines is dealing with the funding, dealing with like, are we trying to push a certain drug over another drug? It's the flavor of the day. Depends on what preceptor you have and who's teaching it as to what you will follow. Okay, just when you're writing your note, your clinical note, annotate what you use, because that's why you pick what you pick. Okay, as long as you do that, you're fine. So, track 1, this is the one that we prefer because you see that this as needed reliever, so when they have an exacerbation, is what they're using on a day-to-day, if they needed to, right? So these are like as needed things. I'm a step 1 or 2. I'm not having a lot of exacerbations. There's nothing really wrong, right? So I can just be fine with using my inhaled corticosteroid with my formoterol, all right? So This is just the same inhaler. They're using it as a reliever, which is for an exacerbation, right? They had an exacerbation, I need a reliever. And then this is for them because they're milder, right? They're not having a lot of exacerbations, so they're at a step 1 or a step 2. Okay? With your step 3, what you see is this patient is going to be, we need to give them some type of maintenance. So they have the same exact inhaler, but now the dose is different, right? This is low dose, this is low dose, step 4 that changes, low dose as well, right? Now you see that they're changing to the medium dose. Remember how you saw that chart where the doses kept increasing depending on how many inhalations you were telling me to use? So I can still use the same exact inhaler, but I can increase how many puffs they're taking, right? Do I want you to take 1 puff? Do I want you to take 3 puffs? And then step 5, don't worry about this because you would be referring this person, but this is where you would add on a LAMA because they're not responding to anything else that you had on board. So you would put on a LAMA and then you would do all of this different phenotyping to see, like, do you need to be worried about IgEs? Like, what other things are you worried about? So just this, you can just get rid of it because I'm not going to ask you about that. Okay? So step 1 and 2, step 3, low dose as needed, low dose, but they're taking this as a maintenance dose. They're having this on a day-to-day basis, okay? And then this one again is now you stepped up to a medium dose at step 4. Don't worry about step 5. This is supposed to be a simpler regimen because I have them with 1 inhaler, right? I have them with this same inhaled corticosteroid with the formoterol. Are they getting a SABA as well, though? Are they getting a SABA? Yes. Okay. They will always have a SABA on board. Okay. The idea also behind this is that if they're using this, they have that steroid on board. Hopefully they have less inflammation and hopefully they have less exacerbations to where they won't even have to use a reliever. Your track 2 patient, what you see is different here is that you have your inhaled corticosteroid with your SABA or just the SABA alone. This is going to depend on if you feel like your patient is going to be very adherent. Because now we have the SABA in play. I don't want them to always rely on reaching for the SABA because we said if I have to continue to use the SABA, then what? Am I very well controlled or not very well controlled? Not very well controlled. So that's why this one we kind of shy away from. So if you just remember track 1, that's all I want you to know. Only steps 1 through 4. Don't worry about 5. Don't worry about your alternate track because we don't love to see somebody just reaching for their SABA. Now, can you again, based on the guidelines, see some patients where that is the thing? We want them to just reach for the SABA, yes. But just know for in here, you want your low dose inhaled corticosteroid and your formoterol as your first reliever. If that doesn't work, then that's whenever they're going to go to their SABA for their exacerbation. Okay? All right. This is your EIB or your exercise-induced bronchospasm that could occur, which is what we keep talking about. Like, it's a form of an exacerbation that is happening because I went and I worked out. Something that we're going to have to do being in this uniform, right? So if I did, so I'm going to stay in with having asthma. What you can do is you can give me a SABA. So before I go out and I do my workout, 15 minutes before, I need to take my inhaler. And I should also have it on me while I'm working out. Some people feel like because they took that prophylactic dose that they don't need to carry their inhaler, and they do need to still have their inhaler, okay? So 15 minutes before, they will do their SABA. That's what we like to use. We can also have our LABA being used for this, a longer timeout that you're going to use it, but prefer to do our SABA instead. So again, we like our SABAs better. LABA potentially, but not, that's if somebody's like doing 2-a-days or something, right? But they could still just take their SABA again before they start their next workout. It's because of the half-life of this is a lot shorter, and some patients will say like, hey, I'm not experiencing the relief that I should be from my inhaler, and I'm having an exacerbation towards the end of my workout, what have you, or like I said, they're working out several times a day, then you could potentially see this. So know the difference between the time before, 15 for our SABA, 30 for our LABA. And then I also have my leukotriene modifiers, which was my Montelukast, which is the one that we typically will see, but you also have your Zaphaleucus as well. Now with this one, this is not something that they're just taking before they go out and work out. If I only work out twice a week, this is not an option for me because I still have to take it every single day. All right? So I don't need to give this to the patient who is like, oh, well, I don't have exacerbations on, like, some people in exercise-induced bronchospasm can also just be like they're experiencing that bronchoconstriction and it's inhibiting them from being able to work out, or they're working out and they're like, I'm at an extreme shortness of breath. Not for your person who is not wanting to take something every day, because this is an everyday thing. This is not the 30 minutes or the 15 minutes before that exercise. Okay, this is no matter what. Every night I'm taking my leukotriene modifier. Okay, so that's the difference between these three options that we now have available. All right, 14-year-old, diagnosed a month ago, not using any meds. He's saying that he's wheezing and coughing, and it doesn't happen often. His FEV is at 85%. Which regimen is most appropriate? So for this patient, right, he's more intermittent, like a milder intermittent patient, right? He's not having a lot of disturbances. He's only having something occur once a week. If I have a person that's on the milder end of the spectrum, what do I think is a safe bet to just start them out on? Huh?
Albuterol.
Okay, right? He's not horrible. He's not going to be using this often, right? He's not reaching for this. All of these other ones, this is a long-acting type thing. Like, he doesn't need any of this because he's not that bad yet. If he were having this more severely, then yes, we could step him up. If this were an exam question, I would tell you that he is intermittent. Like, I would tell you where he was at so that you would know what drug to pick, okay? I would be like, oh, if he's step 1, which med are you using, right? Oh, if he's step 3, which med are you using, okay? I would tell you. In this situation, he's not getting a combo, so to speak, because he just has wheezing every now and then, right? I didn't give him anything. I could also give him my inhaled corticosteroid with my formoterol, but that would be when he needs it that one day a week. I could do that. Okay. All right, these are different videos that you can use when you start to prescribe these. You can use this website and it has videos that tells you no matter which type of inhaler you use. And it does go up and down sometimes, so I don't know if it still works or not. I didn't try it this semester. But you'll see where you click on the, and it's in several different languages, but you can click on the inhaler that you're giving them, and then it will go through a video to demonstrate to them how they are supposed to properly use the inhaler, okay? So a good resource for you to have. This is just, again, showing you the difference between the types of inhalers and how you're supposed to actually take it. I don't know who's doing all of this. Like, you don't need to turn your head away. Just don't spray it in your eyes. Be ready to take the breath. Like, they don't have to do all that. But it goes through step by step what they're supposed to be doing. They do need to wait at least 30 seconds before they give themselves another dose. So if they're like a person who you have on several different puffs, because you could do like 1 to 2 puffs depending on what's going on. If they're a person who has several puffs, just make sure that they take a little space in between them doing it again. This is the spacer that I was telling you guys about. So you take your inhaler. This canister, when you order it, is not in this plastic piece. They will then take that, they put it into the plastic piece, and then they stick this into one end of the inhaler, and then they take the cap off the other end. This is what will go in their mouth, okay? So when they press down on this part, it will suspend the medication into the chamber for them to just continue to breathe. If you have a smaller peds patient, this then has an attachment where you could put a mask on it, and then it goes over their mouth and their nose, again, so that they can just breathe in and out, and they're getting all the medication that's been suspended in the chamber, okay? So that's the difference between those. If they're getting that inhaled corticosteroid and they're in that moderate or high dose, and they're in the moderate or high dose, we should be giving them the spacer so that we can decrease the risk of them having those infections, because again, it's the steroid, right, that they're getting. So anytime you see a moderate or a high dose, they should have a spacer on board also. And then what do they need to do after they take their inhaled corticosteroid? Wash what? The mouth and all of the things that they use. This is, again, just how to use the spacer. We already talked about that. This is your DPI. They like to turn their head. This is the DPI. Again, just make sure that your patient has the capacity to be able to disturb that powder to get it into their system. If you're ever in like an inpatient clinic setting, your patient is telling you that they're reaching for their reliever more often than not, then see if they have a DPI and try to actually watch them take an inhalation and see if they can do it. Most of the time they can't do it and we just switch it to another formulation. That's usually the easy fix for this issue. All right, tobacco cessation. This is going to require your patients because people who smoke, people who dip, people who nicotine, whatever, all the things, they have to want to not do it, right? We all know that we say in front of everything, smoking cessation, stop doing it, lose weight. Like those are our typical things, right? Eat right. So this is going to look at some of the drugs that we have whenever we're talking about cessation. So again, we have hotlines. We also have pharmacists that specifically help with smoking cessation that you could refer them to. So there's clinical pharmacists and they will go through, figure out how many packs a day the person smokes, get them their patches, gums, lozenges. We have all these different options. Or you can also do it yourself. If you don't want to, you have a resource to use because we do have these people that are available to do that, our pharmacists. Also, you have a hotline for them to call, the 1-800-QUIT-NOW, and this just kind of helps encourage them to quit, go through the whole thing. So your job is to just ask them if they want to quit. First, you're asking them, do they smoke? If they say yes, or if they use any nicotine products, if they say yes, then you're going to ask them if they want to quit, and we walk them through and support them. You're going to have to ask on several visits, likely, to keep encouraging them to go ahead and to quit. So ask, advise, assess, assist, and arrange is what you're doing. If they don't want to quit, don't call them names, don't yell at them, don't try to force them. It is a decision for them to make, right? And some people get very frustrated because it's like, you have this issue, I have the solution to help you, why don't you do this? Some people, it's not an issue, that's just what they want to do. It is a habit that they could potentially break, but they have to want to break the habit, right? So just be empathetic, okay? It's like the diabetic person that we talked about who still eats horribly. Like, just be empathetic and continue to encourage them every visit. That is your job. Your job isn't necessarily to make them stop smoking, but it's to continue to remind them that it is an issue that is contributing to probably several things that could be going wrong, and you provide them the resources whenever they're ready for them. So, again, we have several options that are available. So we have nicotine gum, inhalers, lozenges, nasal sprays, patches. These are our tablets, our prescription medications that we have on board. Several different combinations that you can use. So like for people who have certain vices or habits that they're doing, just like some people are just used to picking up a cigarette and smoking a cigarette. Some people are used to using pouches because that's how they get their nicotine, and so they're used to that action of doing it. So when we look at like our lozenges or when we look at our gums, these are things that they still get to park in their mouth, and it kind of mimics that thing, and then it's giving them the nicotine that they were getting from the dip or the cigarette, and then it slowly starts to taper them off of it so that they can not want to use it anymore, okay? So this comes in several different strengths, and then the frequency in which they are using them will change over time. The only thing that's a little bit different with this, they're going to chew it for a little while, and then they just kind of leave it in their mouth, which is weird of a gum, right? Most of the time we're chewing gum. This, they chew it, and then they park it in their cheek and leave it there, okay? And then they'll spit it out, and they'll get a new gum, right? So that's one thing that I want y'all to know. The gum is kind of weird. All of these doses are based off of how many cigarettes they were smoking per day prior to, okay? So prior to them wanting to stop smoking, the more cigarettes they smoke, the higher your initial dose will be of that nicotine replacement because you're replacing the nicotine just with a drug, and then you will slowly start to control and taper them off of it so that they can quit. All right, so what they're doing, again, they're mimicking that thing that they were getting from the cigarette, that they were getting from the dip. So binding to those nicotinic receptors, okay, doing the same exact thing that the nicotine was doing for them. What we're using it for, tobacco cessation, so over time, we will start with a higher dose and then you'll start to see us decrease. Can they get this over the counter? Absolutely. But do we have it for free for them in the pharmacy? Also absolutely. So for you as a provider, you can help them save a lot as well by just ordering this through Genesis or again, referring them to that clinical pharmacist who can help you with that. Your adverse effects that you have, central nervous system things, GI issues. When you're looking at your inhaler, again, thinking about all of the different types of things that can happen because of the delivery system, it's in your mouth. So make sure that you're seeing that understanding that agitation could also happen. And then your throat irritation again from your inhaler. So this is going to happen no matter what. This is also by way of them stopping the nicotine. This is also something that's going to happen anyway from the withdrawal. They'll get headaches. They'll have like jitteriness and all that thing, all those things. So make sure that you're understanding that this is something that, yes, is a drug, but could also be because of them withdrawing or stopping the nicotine. All right, have we seen this before? We've seen this before. Same exact thing, right? So make sure you're familiar again with your mechanism, that dopamine and your norepi inhibitor. So I'm trying to let it hang out for a little bit longer. Same exact drug, right? They're both called bupropion, but when we're talking about smoking cessation, it's Zyban versus when we're looking at depression, it's called Wellbutrin. Same drug. When we look at our adverse effects, same things that we talked about before. So you can have a person who gets weight loss. We like that. But you also have that increase in the sexual dysfunction, not sexual dysfunction, increase in the psychiatric disturbances that can happen. So that's your black box warning that you have for that psychiatric disturbance. So you have two drugs now that we talked about in this lecture that have a very similar black box warning. Looking at the other things, kind of link these two together, decreased appetite with your weight loss, right? Because those are going to go together. The irritability is also another thing that's happening with withdrawal, right? They're going to be more irritable because they're stopping the nicotine. So just kind of keep that in the back of your mind. The seizures, remember that was the big thing that we talked about last semester. So if somebody has a decreased seizure threshold, make sure that you understand that you're not going to want to give them this medication. If you do, you're going to be very careful in monitoring that patient. But for the most part, I have never seen any of our pharmacists or a provider want to risk giving this to a patient who has a seizure disorder. And most of the time, if they do have a seizure while they're on it, we stop the medication. So you might find out the hard way, but when it happens, like nobody wants to mess with that or have to monitor it. And then you see the sexual dysfunction is still present. We're not talking about depression, but if you were comparing it to the antidepressants, and of course this one isn't as bad. Talked about our black box warnings that we have. So again, there are psychiatric disturbances and the potential for those seizures because it's dealing with bupropion. Your contraindications, same thing here, right? Seizures, anorexia, because I told you that this is going to make them lose weight. This can then contribute to a person's anorexia because they're seeing a result in them losing weight. So then they can start to abuse the medication. So that's why we're watching out for this in a patient who has that type of eating disorder. And then alcohol, benzo withdrawal, because they're already going to be going through it, and now we're putting them through things that look similar, right? It's increasing the risk of seizures if I have somebody who's going through alcohol withdrawal. Separate your 2 weeks with your MAOIs if you are using those. Last slide is going to be your varenicline or your Chantix. Make sure that you understand this drug and the mechanism because it is a drug that came out and was really, really big, and we prescribed it a lot. And then as we went on with it, the side effects and the people having these abnormal dreams kind of came out, and you don't see it used as much, but we still do use it. It is an effective drug. So when you're looking at this, your alpha-4, beta-2 nicotinic receptor agonist, so we're just kind of replacing again for that patient. We have a starter pack that this comes in, so the first time that it's ordered, you would order the starter pack. And then you start to change their dose as they go along, and they come in different packs after that. Okay, so again, it's a tapering effect on all of these smoking cessation type things. When you're looking at your adverse effects, you see again typical things: the depression, the headache, The suicidal ideation and these abnormal dreams are the biggest things that we start to worry about in these patients. So a lot of times people will stop taking this medication because of those vivid dreams. They'll say like, oh, it seems so real. Or I feel like I killed this person and it feels like it actually happened. So that's, again, the thing that starts to mess with these patients. They're like, oh, I'm good on this. Like, this is making me feel crazy, okay? So this is a big reason why people will stop taking it. Your warnings, CNS depression occurring, and then your somnambulism, or where your patients will start to kind of look at themselves as something is wrong and like harming themselves or others, which we don't want, not from them stopping. I would rather them smoke, and that's a bad thing, right? But I would, don't hurt me because of the medication. So keep these things in mind. Your memory joggers are listed here. So just kind of go through these. It kind of sums everything up for you in a neater way. Again, remember to study the drug classes and then just put those very couple unique things that were depending on if it was asthma versus if it was COPD. Okay? See y'all tomorrow.